Welcome to Your Healthcare. I'm Dr. Amit Lahav, and in today's show, we're going to discuss regenerative medicine and stem cell. In this show, we discuss medical-related topics to educate you on the best health decisions you can make for yourself. How much do you know about regenerative medicine? Platelet-rich plasma, stem cells. There's a lot of things out there, but what are you really getting? What's covered? What is the best thing for you, for your health, for your joints, muscles, or tendons? We're going to enlighten you today with Andy Shepard from Plymouth Medical, who will educate us on some of the things that are out there, including what his company has to offer to you to make you better. You're watching Your Healthcare. I'm Dr. Amit Lahav, and we'll be right back. Welcome back to Your Healthcare. I'm Dr. Amit Lahav. We have a very interesting topic today for all your audience out there on something that's really technologically advanced, and it's definitely out there in the healthcare industry regarding regenerative type of medicine, stem cells, platelet-rich plasma, things to help enhance you and maybe sometimes keep you away from surgical interventions, postpone any surgery for you, and maybe enhance your quality of life and your activities. We're happy to have with us today Andy Shepard from Plymouth Medical, who will help enlighten us on some of the concepts that are out there regarding some of the products that can be offered to you and where to find them. What is the best one for you? How do you know what you're really getting in an injection or any type of treatment? And this is some of the issues we'll discuss today. Before we jump into our talk here, let's watch this video on some of the platelet-rich plasma and some of the options that you have out there currently from one of the top institutions today. We'll go to the video, please.
The Johns Hopkins Musculoskeletal Center offers non-surgical options for patients experiencing musculoskeletal pain, sports-related injuries, and chronic conditions. Our team of experts offers platelet-rich plasma injections to help alleviate pain, improve mobility, and decrease inflammation.
Your blood is made up of plasma, white blood cells, red blood cells, and platelets. Platelets are vital proteins that promote cell function and immunity. Platelet-rich plasma, also known as PRP, is blood that is naturally enriched with concentrated platelets to promote and re-engage the body's healing process. Blood is drawn from the patient's arm and processed in a machine called a centrifuge. The centrifuge separates the blood's components into three parts: platelets, white blood cells, and red blood cells. The concentrated platelets are extracted, combined with the remaining plasma, and injected into the affected area. It is a minimally invasive, non-surgical needle procedure which enhances healing with the concentrated body bioactive factors. The procedure has fewer potential side effects, and the patient is able to resume normal function and activity immediately after the procedure.
At your initial consultation, we'll review your medical history, physical exam, and imaging. After discussing your diagnosis and prior treatments, we'll determine if PRP is an appropriate option for you and how it may be beneficial. During this appointment, your blood is drawn, processed, and readied for injection. Numbing medicine is applied sparingly around the injection site to offset any discomfort or pain from the injection. Your blood, enhanced with concentrated platelets, is injected into the affected area and guided by real-time imaging. The procedure appointment takes no longer than 1 hour, and the injection results are expected to take effect in about 4 to 6 weeks.
Unlike a cortisone and other injectable medications, PRP is a natural substance derived from your body, limiting adverse reactions. As with any injection or needle procedure, there is a risk of infection, bleeding, and damage to local structures.
Please speak with your physician about the cost of each PRP injection. 1 injection may suffice. However, some patients may need 2 or 3.
Thank you for choosing Johns Hopkins Medicine.
Well, this gives a little introduction, again, on something more specific, platelet-rich plasma, which is called PRP. And we're going to jump right into introducing, again, Andy Shepard from Plymouth Medical. Tell us a little bit about the company and what you have to offer to our patients.
First of all, I'd like to say thanks for allowing me to come on the show today to talk about regenerative medicine, and it is a fascinating subject. The company, Plymouth Medical, has been around for 14 years this year, so we're no strangers to this. It's changed a lot over the last 14 years. But the function of the company is to specialize really in helping patients that maybe are not good surgical candidates, or helping patients that are in pain to get better. We do that by curating a variety of different products, specifically in and around, we call it, the term we prefer is orthobiologics. And we identify the best possible products in the industry, and then we go out and we train physicians such as yourself, orthopedic surgeons, PM&R, pain management physicians, interventional spine. There's a whole host of different physicians that use these types of treatments. But we aim to bring the best possible products to the market that are going to give the patient the best chance at healing.
And that's actually a very important point also, because there's a lot of products out there in the healthcare industry, in the system. How do you know what you're getting? You know, there's really differences between some of these products out there. And I know you have specific information on some of these things that are out there.
What is fascinating, you talk about pretty much any other drug, you can give a dose to it. You can say, okay, this is 500 milligrams, this is, X units. You can very specifically tell a patient what they're about to ingest. And obviously then, based on the physical size of the patient, or the given pathology, or the given disease the patient has, you can tailor-make the treatment to suit that patient. The thing with orthobiologics, the things with these types of treatment, is that each patient is essentially giving us the treatment themselves. We're taking it from the blood, from the bone marrow, sometimes from the fat even. And that means we get a very wide spread in terms of what is delivered back to the patient. We'll talk about this later on, but that has something to do perhaps with why insurance don't necessarily want to cover this, because of the variability in what comes back and what gets delivered to the patient. The other side of it is there are a lot of competing companies manufacturing different products in this space. The problem with that is that there is a very, very wide spread, and we're all kind of lumped in together. Everybody calls it, well, it's PRP. Even the Johns Hopkins video, I doubt anybody would have picked up on this, but they showed a very small test tube at the start, but then later on showed my centrifuge, which was the thing that was sitting behind them. That test tube doesn't fit in that centrifuge, and those test tubes deliver very, very low platelet yields. And what we have, and we'll show you a little bit later on, we've got a bit of a show and tell, what we deliver is a much greater dose. Dose is the critical factor. And so if you've got this wide spread of products, you need to understand, well, you can dismiss quite a few of them based on the fact that they don't deliver these high doses.
Right, and that's essentially like treatment of any medical conditions. If you have high blood pressure and you take up too low of a dose, well, you're not really treating your blood pressure appropriately. You have to be at the right dose for it. And same thing with PRP or platelet-rich plasma. You have to have the right dose, because the body has the ability to heal. What you want to do is you want to take that ability to heal, concentrate it, and put it where the issue is.
I couldn't agree with that more. That's exactly the point. Our body is beyond incredible. For most people, you're going to live to 80 or 100 years, a spread between 80 to maybe even 100 years, and you're self-healing. You know, as long as you don't have a traumatic injury, things are going to fall off and things are going to get creaky as you age, obviously.
Like a car.
Exactly. But for the most part, our body does a really good job at repairing itself. When we start using these orthobiologics products, we're really tricking the system. What we're able to do is take almost the exact mechanism our body uses to heal itself, bundle it all into a very concentrated sort of treatment, and then deliver it to exactly where it needs to be delivered. So instead of relying on the body to kind of tick along, we're kind of supercharging that process. And that you can't just do that with the best will in the world is not going to do it. There's a lot more to it than just sort of going through the steps. And that's when we start understanding dose. And that's when we start looking at the clinical data that supports this. It's quite funny. And you being an orthopedic surgeon, well, let me start by saying this actually. You being an orthopedic surgeon and me sitting here saying, hey, we've got something that could potentially delay or do away with orthopedic surgery is a little bit of a bold thing to do, right? But that's the reality of these types of treatments, is they might make people's lives better while they're waiting for their surgery, or it might be able to delay that surgery for a couple of years and give them a little bit of a better quality of life.
But there's also different techniques to treat different issues. If you're looking at arthritic joint versus a chronic tendinitis or a fracture that's not healed, with using things like what you have with PRP and regenerative type of medicine, you can get the fracture to heal. You can get the tendinitis to subside. Arthritis, maybe we're not quite there yet. Maybe we are postponing. But again, we're trying to give a better quality of life, better functionality. And as a surgeon, I always tell the patient, we do the right surgery for the right person, also at the right time. So if you don't have to have surgery now, surgery has pros and cons. There's risks and benefits. But if we can postpone it another 5, 7, 10 years, why wouldn't you? Your best product is what you got, right? When you buy a car off the lot and you take it, that's the best the car is going to be. Once you start changing parts, things are a little different. They still work, it's still good, but it's not that first ride that you take off the lot. And that's really what we're trying to do here. Is like, keep what you got. The car is still good. Make it run.
Yeah, preserve it. Preserve the clutch, preserve the alternator. And if you can keep it running for as long as you can, and then when ultimately you need to change the rotor, whatever it is, change it. But keep hold of it for as long as you can. Keep it functioning and keep it working. One of the really interesting things is when we get asked this an awful lot, will this work? Will this work on me? And the trouble is, of course, terms and conditions apply. Not every patient is the same. Now, you know this better than anybody, but you measure osteoarthritis it's a pretty short scale, right? The KL, the Kelson-Lawrence scale.
Yes. It's
1, 2, 3, or 4. And what that tells you is if it's 1, it's very mild, and if it's 4, it's pretty much catastrophic bone-on-bone grinding joints. And so, a lot of people will say, well, will this work? And the first question to ask is, well, it depends on where you sit on that. It depends on how advanced your osteoarthritis is, talking about arthritic joints. And obviously, as with all treatments, it works better the further down, the earlier on you get it. And so the argument we're making, and it's beginning to resonate because the cost is beginning to come down to something that is reasonable, is if you do have, if you're beginning to experience problems with your joint, maybe you're getting to kind of my sort of age and things are creaking a lot more than they were 10 years ago, now might be a good time to start thinking about investing in preserving your joints and preserving your alternator, as we just
and some of it is actually investment in yourself. Right? You're investing in your body to get the best out of what your body can give.
What will never cease to amuse me is what happens in the aesthetic market. And the reason I mention that is because some of these products are actually used in aesthetics. And we find that if you've got a patient that's coming in and wants to look better, and you say to them, well, this is going to cost X dollars, they don't think about it. The pocketbook comes out, they'll write the check right there or pay the credit card. If you say to a patient that's got a creaky knee, well, this is going to cost the exact same amount, well, shouldn't insurance cover it? Shouldn't? And I scratch my head because, I can't help thinking that your physical well-being, your physical health is that much more important than the aesthetic. You can always slap a bit of makeup on if you're that way inclined, I don't know. But point being, there is a fear for patients paying out of pocket for these treatments. And I really would like to get into that a little bit later on about why they're not covered and why it's worth really seeking out the right type of treatment. And it is frustrating. Perhaps they should be covered at this point. There is enough evidence to support that.
Absolutely.
But I think for patients watching this that maybe are sitting there thinking, yeah, it might be time to start thinking about these treatments. investing in yourself is never a bad thing.
Absolutely. And that's actually a key point. Now that you actually touched on some of the other aspects of where these products are being used, let's go to my next presentation, please. I want to give a little bit more of a background on some of this regenerative medicine and PRP. So we're going to look at PRP and stem cells. So I want to give a little bit again of a background of what we're talking about here. So the first thing is, again, is platelet-rich plasma, which is what we're talking with Andy Shepard here from Plymouth Medical, is a treatment that uses a concentration of platelets that are in your body, in your own blood, to promote healing. The platelets contain certain growth factors, and that's really what you want, that stimulate cell regeneration and tissue repair. And this is just a picture showing using it in the shoulder, but it can work in a lot of other places. So how does it really work? Well, a small amount of the patient's blood is drawn. And again, that's also relative to how much you're taking and what you're trying to treat. The blood centrifuged to separate the platelets from other blood products. The platelet-rich plasma is then injected into the area that is affected, and that's really where the magic takes place, so to speak. So it's really being used in a variety of conditions. Musculoskeletal injuries, orthopedics, which I'm in, and that's what we're talking about with Andy here as well. But it's also used in other things, and Andy just touched upon it, even cosmetic things like hair loss, skin conditions like acne, scars, wrinkles, and so forth. And again, osteoarthritis is a very big one, but it also involves different tendons, fracture healing, back, things like that. So again, in platelet-rich plasma, or again, what we call PRP, you take the whole blood, you centrifuge it, you kind of separate the components for it, you separate the blood, and then you inject it into wherever you are going to inject it. And here we're just showing injection to a knee, which is a very common area. We do utilize this type of product. So what's the recovery? Well, after PRP treatment, patients, you can experience a little bit of bruising, a little soreness of the injection, like any other injection. It may take a few weeks to see the full benefits, and that's really important. And when you get other types of injections, like cortisone injection or steroid injection, sometimes you get the relief very quickly. But in PRP and some of these regenerative type medicines, it takes a little time for the body to kind of kick in and treat the area. So it takes a little time, and the patient has to understand that. And then multiple treatments may be required, like Andy touched upon as well. It may not be just one. It may be more than one, 2 or 3 or whatever it may be. But if there's progression of healing, that's what you want. Now, a key point here, and this is a little bit of a busy slide, and we'll get to it with Andy a little bit later too, it's the types of PRP. So when you go and somebody says just PRP, platelet-rich plasma, what does that mean? There are a lot of different varieties, and the key point is it's good to know what you're getting, or it's good to ask the right questions when you're seeing the physicians of what you get. And just to kind of sum this slide up, there's things like leukocyte-poor PRP, or leukocyte-rich PRP, fibrin-rich PRP, pure PRP, and advanced platelet-rich fibrin. So there's just different variations of what it is, and it comes back again to having different companies that are out there, and what are you really getting? What is the best product that you can have? There's also super concentrated PRP, or autologous conditioned serum, platelet lysate, just different variations of what you're getting. So a PRP is just like saying, I'm going to go get a car. But what car are you getting? Well, there's a lot of variations of cars. It costs a lot more to go kind of to the higher end cars. But the product can be better. So what are you really getting on here? And this is something we're going to speak with Andy very clearly, because it's important to understand what you're getting and the right questions to ask. So what is also a stem cell? There's regenerative medicine stem cell. A lot of people say, oh, I got a stem cell treatment. But what are you really getting as a stem cell? So a stem cell is a mesenchymal cell that it's a primitive cell. And the point is, it can turn into any cell that you want it to be. It didn't make that decision to be anything yet. So it can reduce inflammation. It can fight apoptosis or cell death. It can become bone, muscle, cartilage, fat, whatever it may want to come, and it can also replicate. So how do you take this cell and put it in the right place to do the right thing and give it the right signal to become whatever you want it to be? And that's also a key in treatment it's not just getting a stem cell. How do we get that stem cell to do what you want it to do? So again, looking at a stem cell is a single cell that can really become anything. It can replicate itself and become more of these stem cells in a bigger area, or it can become differentiated into something specific. If it's a muscle, if it's a bone, if it's a tendon, whatever it may be, it can become something else and commit to that line. But the key here is, how do we make it commit to what we want or to grow? How do we grow a whole sea of cartilage? And that is some of the issues that we're having right now. We can only replicate in a very small area, but we can't replicate cartilage entire arthritic knee to kind of recoat the knee. We're working on it, but this is where technology has something to do with all these research of how do we get this to work the way we want it to work, not confuse the cell and become something else. So a stem cell, at this point time only, a few FDA-approved stem cell-based therapies are available. Most recently, hundreds of businesses around the country, referring to themselves as clinics, have become marketing various versions of the stem cell that promises to help patients with serious conditions, even like Parkinson's, neurologic conditions, and more ailments like joint pain. But in reality, most of these types of stem cell therapy do not use real stem cells at all. It's just using the word stem cell, but the product you're getting is not a stem cell. Rather, they remove just tissues that presumably contain some stem cells from one body part and essentially put it into another body part. But is it going to do what you want it to do? And the answer most of the time is no. What are you getting? What is the product? And there's specifics on this type of stem cells, where you retrieve them and how do you manipulate it and put it in the right place to do the right thing. So regenerative medicine and orthopedics use biologic substances and different techniques to harness the body's natural healing process, as we mentioned before, for musculoskeletal injuries and conditions. We try to put it in the right place to do the right thing. So again, different applications exist out there, from orthopedic sports medicine, neurological disorders, aging and longevity. That's one really important thing that's out. How do we live longer, better? Cardiovascular regeneration, help your heart. Dermatological and wound healing. How do we get a wound to heal better, the skin to look better? Oncology, cancers, immune disorders, get rid of different diseases. These are some of just the state-of-the-line and technologies that are out there to help treat you and really give you the best life, functionality, and comfort. And that's really some of the things that we're going to talk about here, Andy, of how do you know what you're getting and what is some of these things that you can get?
That presentation was so on point. The challenge we have here is that this is a very complicated set of cells and a very complicated sort of process. And what we need to do to make it work is make people understand it. And as you pointed out, there's lots of different avenues that we can go down, lots of different pathologies that we can treat, lots of different ways that we can slice and dice this. But what we need to do is make sure patients understand it. Unfortunately, as in any market, there is an underbelly, right? There's a nefarious side to it because there is money to be made. And some of the things that are occurring in this industry, unfortunately, are for way below expectation. Some of these things are, some of these bad actors are promising things like stem cells, and I put it in inverted commas because it very rarely is actual stem cells that are being used. The FDA have a very strong stance on that. And so, you've got to be, as a patient, and I hate to use the term consumer, but ultimately, if you're paying for a procedure, de facto you become a consumer. You have to be very savvy. You have to be very careful. And these treatments have to pass the sniff test. And the beauty of speaking to somebody such as yourself is that you fully understand this. And you don't have to look very far. In Connecticut, in any state in the Northeast, there are clinics that have opened up. I think it would be foolish for me to name them for legal reasons. But there are clinics that have opened up to bilk patients, to try and take money from patients by making outrageous claims, charging ridiculous sums, but ultimately delivering very, very little. And the crux of today, if we can get through today and inform a patient, what should I be looking for in terms of seeking out the right treatment and avoid these bad actors, that would be a win. I think even if just one patient does better, that would be a win.
Well, you want to be an astute patient, a smart patient, and you want to ask, again, the right questions. And these are some of the questions that I want you to help our patients say, when you go to a clinic, what should you ask? Because when they offer you, oh, we can do a PRP injection, or we can do a stem cell injection, regenerative type medicine, what should we be asking?
The critical thing, right? How should you evaluate what it is you're walking into? So what we'll do, if it's okay with you, we'll break it down into a couple of different chunks. So there is PRP, and then there's everything else. And the reason I say PRP separately is because really that's the cornerstone of all of this. If you get that bit right, you may not need the stem cell stuff. You may not need it. Good PRP delivered right, as you mentioned, targeted and accurate delivery to the right patient at the right time in their disease progression can be very, very effective. I've got some clinical data that I'll share as we're going through this. But ultimately, PRP is kind of the thing. A lot of patients are wowed or wooed by the word stem cell. Since the 1980s, it's been on TV. I'm obviously from the UK. It's here. Stem cells are going to fix everything. That's the core of all of this is stem cell, stem cell, stem cell. People then say stem cell. Everybody drops their guard. They think, oh, stem cells. Since I was a kid, I knew this was the future. That's where we start getting a little bit nervy, a little bit scared. But back to the PRP. If you're a patient and you've got any number of different things wrong with you, so the obvious one is knees. This is your realm. I don't want to stand on your toes at all here, but you know full well. If you've got knee osteoarthritis, which is extremely common, it usually occurs on the medial compartment, that is the inside of the knee. That accounts for a good deal of what we treat with PRP. If you choose you're going to go and get a PRP, the first few questions you should ask is, has it been properly diagnosed? The physician you can't walk into a nurse practitioner and they say, hey, you should have this $3,000 package. What it requires is an MRI. Well, you tell me, what would you, in order to diagnose knee osteoarthritis, what steps would we go through?
So first of all, you got to hear the story.
Yeah.
Right? So history is very important for a patient. Physical exam.
Yeah.
Let me take a look at your knee. How is your motion? Where's the pain? Do I get what we call crepitus or crunching in the knee?
Yeah.
Then I use radiographic guidance. Let's look at an x-ray. Mm-hmm. Again, you mentioned the sort of grading of x-rays for arthritis, which is what we look at.
Yep.
How bad is your arthritis? Is it mild, moderate? Is it severe? Because that can also indicate where the treatment is.
Yep.
And if you're showing, you're at the mild to moderate, if we want to get a little more information, do we use more advanced imaging, like MRI, for instance? So putting all that together, we decide if the patient then becomes a good candidate for treatment like you're providing.
And that's the start point, is to get a diagnosis and it not just to be guesswork, is to work with a professional, an orthopedic surgeon or a pain management physician, to rule out all of the other different things that could be causing that pain. There could be a number of things. There could be a loose body in there, it could be a meniscal tear, it could be any number of different things.
And sometimes all knee pain is not just orthopedic knee pain. It could be something vascular, it could be neurologic. Yeah. So that's why you have to eliminate all the noise and concentrate on what is the right diagnosis. Then you can treat that diagnosis.
So the first step is understand what is going on. For a knee, that is get that solid diagnosis. If then you might be offered a number of different choices, and it's very common that first choice might be lifestyle modification. It's not wildly uncommon that patients that are a little bit more, how should we say politely, a little heavier set, obviously the joints are taking the burden of that weight, that extra 20 pounds, hold a 20-pound weight for half an hour. When you put it down, it's a hell of a relief. That 20 pounds that some people are carrying around, a lot of us are carrying around, has a massive impact on the joints, on the health of the joint. So often the first thing a physician will suggest, if it's mild to moderate osteoarthritis, is, hey, it might be worth getting an exercise program down, it might be worth losing a bit of weight. They might even help that along by giving a cortisone injection. Cortisone injections are very effective to deliver pain relief in the short term.
Yeah, it's literally like taking a Motrin and putting it inside a joint.
That's exactly what it is.
That's really how it works.
Yeah. You mentioned Motrin as well. Non-steroidal anti-inflammatory drugs are commonly prescribed in early stage osteoarthritis. They take out some of the pain. There is some concern that they may damage him for the cardiovascular. They may have an impact on the heart health.
It's not a good long-term solution.
It's not a good long-term solution. There are gastro problems as well. And so the orthopedic surgeon or the physician is going to look for solutions. Assuming you are not a good surgical candidate, there are obviously a bunch of patients that are going to go in and will need a knee replacement or a cleanup, a debridement, a scope, something like that. But assuming you are not at that end of the spectrum, the physician's going to start steering you towards treatments. And there are a number of different treatments in the marketplace. So we talked about steroid. Don't love them because they actually probably do more damage long-term. I don't know what your opinion on that is.
With repetitive injections
Yeah.
and too frequent injections, in the long term, it actually will destroy your joint over
Right.
time.
So good as a stopgap, but probably not a good long-term solution.
Agreed.
Then we move into products that are commonly called visco supplements, and you probably have some experience with these,
Yeah, we call it lubricant injection,
Lubricant
or
injection.
gel injections are termed out there.
which is hyaluronic acid. It's basically a pre-filled syringe with a very viscous liquid in them, and they're injected. The efficacy on those things usually seems to, according to the clinical data, seems to run out at about 3 months. The claims that the manufacturers make is obviously quite a lot longer than that, but they are interesting, and they're often covered. So usually that's the first thing you're going to get when you go to see a decent physician is probably a visco shot, right?
Yeah,
Is that-
I mean, you analyze conservative, semi-steroid, visco injection or gel injections, and then we start going next level.
So let's assume you've done all of that sort of stuff, and now you're not a surgical candidate, but orthobiologics, now's when we start thinking about what's the next step. Visco is not really giving me the relief that I need. What should we do? So now's when we start thinking about possibly using PRP. So the questions, back to the original thing, the questions you should be asking are, how much blood are you taking? It's absolutely critical that you're not using one of those little test tubes. There was the thing that was shown on the video earlier with that small test tube, that's not going to cut it. And what I'd like to do is start talking about one of the first clinical studies that I think is relevant at this point. And the argument that I get into probably monthly and often with orthopedic surgeons is that a lot of people will look at it and say PRP doesn't work. And they'll reference a number of studies. And when they reference their studies, the reasonable response from me is, yeah, you're dead right. In that study, we proved that PRP did not work. There is a study, I've got it here. I'll give access to these after the fact. We'll put them on a website for you to get access to. But when you look at some of these studies, what you begin to realize quite quickly, and as we discussed at the start, is not all PRP is created equal. There is the study that I'm referencing that I always end up getting into arguments about, where they used a product, I again probably won't name it, but the total delivered dose of platelets was 500,000, sounds like a lot, 500,000 platelets were delivered, and they actually had 3 injections of that. And it absolutely failed. Patients with stage 2 to stage 3 to stage 4 osteoarthritic knees, KL 2 to 4, had no discernible benefit. In fact, the sham injections work better. And so I'll often walk into a conversation and say, hey, I read that study, it was from 2015, PRP doesn't work. We understand dose a lot better now. So remember that number 500,000, that was the delivered number of platelets. When we create PRP using the system that Johns Hopkins showed there, the system that is commonly used in a number of the major hospitals, Hospital of Special Surgery, the Mayo Clinic, Cedars-Sinai, we're creating a product that delivers close to 10 billion platelets per injection.
So I want to emphasize 10 billion as opposed to 500,000.
10 billion. Do you know what the difference between 500,000 and 10 billion is?
Yeah, it's a lot.
20,000. 20,000 times more. It doesn't sound right. It sounds like I'm making that up. But if you get a calculator, I can show you the math. So what we see when we see these physicians talking about, hey, this PRP didn't work. Yeah, try one that's 20,000 times stronger, and then let's have that conversation.
Well, it's almost like putting oil in your car, right? I'm going to put just a little bit oil and see if the car runs well, as opposed to putting the appropriate amount of oil and the car runs great.
That's exactly it. We have to make this easy for people that aren't in the medical industry to understand. I always joke about the dose response is, and it's obvious, the dose response is critical. The easiest way to understand that is alcohol. There's a huge difference between having a glass of wine and having a bottle of wine. The outcomes are often dramatically different right between the two.
Absolutely.
So when we talk 500,000, maybe that's a sip of wine, and what we're doing is, putting a bottle of whiskey in there. We're getting the desired result. In the last couple of years, there's a couple of really fascinating studies, one by a guy called Bansal, and then it was repeated in California by a guy called William Berrigan. Berrigan is an absolutely fantastic physician. I've spent a lot of time talking to him about this. And they've identified that 10 billion seems to be the dose that we want to treat a knee. That's the goal we're looking for.
And that's a difference of your product too, which is one of the questions that should be out there.
You need to ask. If you're at the physician's office and you are about to be treated by PRP, they're talking you into it, do you have a rough idea of the dose that you're going to be delivering? That's the critical question. So what is it you're doing? How do you know what you're delivering?
So the numbers you gave are obviously something that our patients should know. What is the dose of PRP?
What is the dose that you're delivering? It's often the case that they won't understand what the dose is. They won't know specifically because that would require taking a CBC, running tests and analysis. I have a lab in Brooklyn, that's where we're based. We do an awful lot of testing, but it takes a long time, it's quite expensive. So what we do is we paint with a broad brush. What we know is that we know that most patients have a baseline platelet count between 150,000 to 400,000 platelets per microliter. The reason we want a high blood draw, 60 cc's, which is just a little bit over 2 fluid ounces, because when we've processed the sample, for patients that fall within the normal ranges, we're getting very close to or exceeding that 10 billion dose. That's why we take so much blood. That's why one of the questions you should ask is, how much blood are you taking? If they say 10 cc's, they're miles off. If they're saying 60 cc's, okay, now we're talking.
So that's actually a really important point. And on that point, we're going to take just a very short break. We're here with Andy Shepard from Plymouth Medical talking about regenerative medicine, stem cells, and PRP. I'm Dr. Amit Lahav. You're watching Your Healthcare. We'll be right back. Welcome back to Your Healthcare. I'm Dr. Amit Lahav, and we're here with Andy Shepard from Plymouth Medical speaking about regenerative medicine, stem cells, and PRP, or platelet-rich plasma. We really finished at a good note, a good question that really the consumer or the patient should ask the physician of what really they're getting. How much blood are you taking? So you get the right amount of platelets in that injection when you get into the right place. If we go to another video, I'd like to show you again just a little bit more on this PRP. If we can get that going.
PRP is platelet-rich plasma. What it is in the last few years, we have learned that the body has its ability to heal itself. With PRP, you come in, we draw your blood, we spin it down, we concentrate their platelets so they're concentrated much greater than they normally would be in the system, anywhere from 2 to 8 times. And then we introduce their own platelets into the area of injury.
So first what we're going to do is image your tendon. And in fact, on this image, you see the bone, but you also have some calcium deposits in the tendon itself. Pretty significant partial tear right there. So I would imagine your pain is really up in here. Does that hurt up there?
Yeah.
And that's exactly where it is on the pictures.
So this injection, where does the blood go? Like where did it go?
I'm going right into that tear and breaking up some of the calcium while we're there.
We inject the area.
This is another view. We went a little higher up into that hole, and we're filling it with your platelets right now.
And those platelets, in turn, release your own growth factors that you have. And those growth factors are what you use to heal tissue. And we have basically rebooted your healing computer. So it becomes a beautiful alternative for treatments for various ailments that we think appropriate. And nobody rejects their own blood. We definitely have demonstrated for those who have chronic tendonitis or tendinosis, abnormality in the tendon like tennis elbow or golfer's elbow, rotator cuff, Achilles, definitely can help that patient have improved function, have less pain, can do more, And in a good percentage of them, we actually can see a tendon that has healed from a tear. Arthritis, it also seems to have, we're looking at the data right now, it's all new, it seems to have a pretty significant effect, especially if we get to the arthritis earlier. We haven't been able to demonstrate new cartilage yet, but we've been able to demonstrate no progression of the arthritis at a year, and symptomatically they're doing much better. You need some relative rest for the first 2 weeks.
Right now, your platelets are already releasing their growth factors. The process has already begun. You're starting to heal yourself. And they release the growth factors over about a 10-day span. What are my expectations? In 2 weeks, I would expect you to look no different. Between 2 and 6 weeks is when you really gain a tremendous amount on this. Having said that, a lot of patients within the first 2 weeks are already better.
You're tapping into the individual's healing system, which in pure sense is great. It's not an anti-inflammatory, it's not a narcotic, you're using your own system to heal yourself. Now, in a pure sense, how great is that?
So again, just implementing your own body healing potential.
And my passion is to alleviate
these ailments. And it takes a little time, like we discussed before. If we can go actually to the presentation, I'm going to have Andy go through some of these slides with me, specifically for the products that we're talking about now and some of the questions you should ask in order to get the high-end product. So again, on PRP. So for Plymouth Medical,
so this is, and you can see this if you go to plymouthmedical.com, this is largely aimed at the physician so they understand what it is in the process. And I have an example tube that I'm holding here that basically shows what we're doing. So the way PRP is created is, the easy way to understand it is we centrifuge stuff. And when you put something in a centrifuge, essentially all you're doing is applying a lot of gravity to the sample. The fancy term is density gradient centrifugation. The easy way to understand it, spin something around really fast. It's like when you used to hold the bucket as a kid with water, the water doesn't spill out, lots of gravity. What happens is all of the cellular components separate based on their density. And the beauty of this is we know the density of the cells that we're trying to capture. So without getting too complicated, what essentially appears to happen is the sample splits into 2 parts. Now, I'll go on record and say I'm not weird. I don't carry blood around with me. This is olive oil and Gatorade. But it does the exact same thing, right? It separates based on its density in the exact same way as blood does when it goes in the centrifuge. And what happens is all the heavy cells get squashed down to the bottom, all the light stuff gets pushed up to the top. And so in this top portion, in this plasma portion, you have all of the platelets. And it's reliably over 90% of the platelets are in this portion. And what we essentially do is we take that and put it into a second tube, and we spin it again. I don't have the Gatorade for that, but we spin it again and force the cellular components to create, the technical term is a buffy coat or a pellet of cells, which then allows us to have from a fairly large blood draw from 60 or sometimes 120 ml, we're able to concentrate that down to 1 or 2 cc's of actual cells. We're then able to add a little bit of that plasma to essentially to add hot water to the espresso, to make the Americano. We fluff it up to give us the desired amount of volume for the injectate. So for a knee, you might want to be putting in 5 or 6 cc's, but for an Achilles or for a golf or a tennis elbow, you physically couldn't get that. You'd rupture the tissue.
Right.
So you might want it concentrated down to 1 or 2 cc's. But doing this, you don't lose any cells whether you have a small amount or a large amount. This allows you to control the injectate volume. One of the advantages of using this system. And again, we're talking stupidly high numbers, really hard to comprehend, 10+ billion.
But it's really concentration of that healing potential that you want to get, and essentially separate, and take the top of the top and the most of it to put it where you want it to be.
Well, this is the thing. I go on and on about platelets, but what the hell is a platelet, right? And we've all seen, this is the thing, and when this is explained, it becomes really fascinating. We've all cut ourselves. And, you know, once the bleeding stops and the panic is over, you see that it becomes sticky. And the reason it becomes sticky is that platelets account for about 1% of blood. And as they come out throughout the bleeding process, they catch the sides. They've got little tentacles on them and they're sticky. So they'll start the healing process by physically stopping you bleeding out and also stopping pathogens and nasty stuff getting in, right? This is a very basic version of what happens.
Absolutely.
Right?
But it makes sense.
But then what happens, and this is the healing part, and this is where for me, platelets they're little moving medicine trunks, little moving medicine boxes. Once, again, we've all witnessed it. Once the bleeding has stopped, platelets go through this process called degranulation, and that's a fancy way of saying they explode. And when they explode, they release their payload, and their payload is growth factors. And there's 40 known growth factors in a platelet, and there are still growth factors in a platelet that we don't know what their function is. But those growth factors are what start that healing cascade, that healing process. And if you look at that cut, over time you see the edges start to close up. That's because those growth factors are delivering the medicine that is required to heal the tissue. Well, obviously different tissues in the body require different sort of subsets of growth factors. And this is where it gets quite confusing. There's a whole different process called chemotaxis. I won't bore you about that now, but basically what happens is we're taking these little medicine cabinets that are flying around our system, we're taking a lot of them. If you lost 60 cc's of blood, you'd be very, very scared. That's an emergency room visit. We're taking all of the growth factors out of that, and we're putting it right where it hurts, right where the pathology is. And in doing so, those growth factors do exactly what they're supposed to do. They degranulate, they set up a whole signaling cascade around the body that tells the body, hey, there's an injury, we need to fix it. And that's why the healing occurs. That is a very simplified version of a very complicated sort of subject.
But it makes it very clear for our audience to really understand this is what the product you're looking for.
Yeah.
You're looking for the quantity and the quality.
Yeah.
That makes the difference.
That makes a difference, correct.
We can go to the next slide, please. So if we can move to the next one, these are just some of the places that you've worked with. These are, and you can see the really big names on this list.
I mean, this is the point. There's a massive amount of interest in orthobiologics. And as we mentioned at the start, there is this seedy underbelly that is to be avoided. But there also are very legitimate players that are doing research and are offering these treatments. Everybody that was on there, plus quite a lot of others, Plymouth Medical has over 2,000 clients. And some of those clients are huge. The Hospital for Special Surgery, you saw Brian Halpin there, Dr. Halpin, an interesting character, really does a ton of this. We looked at Johns Hopkins earlier. We've been working with them for a number of years. And everybody in between. We work with small standalone physicians all the way up to some of the big institutions, the Mayo Clinic, Cedars-Sinai, these big players.
Yeah, so this product is not just offered in big names. It's offered actually could be right around your block. You
Very
just
much
have to
so.
know what to ask.
Very much. You need to know what to ask, and you need to seek out good treatments. And you know, Plymouth Medical offers. We firmly believe, so the car analogy. We think we offer the Rolls Royce, and I think the data shows that we do. There are other really good cars out there. You know, you don't always have to use a Plymouth Medical product. We would prefer it if you did, for obvious reasons. But if you go to either any of the institutions that you saw there, or you ask the right questions when you're in with a physician. We have physicians in Connecticut. The reason we're introduced actually was Dr. Alice Mayer and her partner, her husband, Dr. Mayer, who are in Connecticut. Both of them offer PRP using our system. And there are a host of other people. I won't get into that. I think that's probably a bit much. But if people want to find out, I'm sure they can go to plymouthmedical.com. They can reach out to us, and we will steer them in the right direction of people that are offering the right types of treatments.
Yes, that's part of Connecticut Orthopedics.
Connecticut Orthopedics, absolutely. Yes, yeah.
And actually, one of the next slide actually shows one of the articles you were talking about, the effect of plasma dose on outcomes after platelet-rich plasma injections for musculoskeletal conditions. This is a systematic review.
Yeah.
This is one of the studies you're referring to, which is, again,
correct.
This is an important one to know. We're just kind of putting it out there. The next slide shows another study, platelet-rich plasma and osteoarthritis knee, correct dose, critical for long-term clinical efficacy. So again, getting the right dose makes a difference. And here, just showing from Plymouth Medical some suggested protocol. Just a lot of numbers. It's a busy slide, but essentially just showing.
Well, if I may, on that one, this is interesting because actually that previous slide was based on my blood. So my baseline platelet on the day, again, I mentioned I have a lab, so I do a lot of this. 250,000 platelets per microliter, which is fairly normal, as I mentioned before, between 150 and 400,000. And what that table showed is it's a concentration table. So it simply shows if I make PRP, how many platelets am I getting? And I think on that one, it was 12.25 billion platelets from a 60 ml kit. Again, those two studies that you showed, Berrigan and Bansal, two of the very important studies, really, they're gold standard studies. They're placebo controlled. Well, Bansal was, Berrigan was a meta-analysis of all the other good studies. both came to the conclusion that you need to be in or around the 10 billion cell mark. So really that table just proves that using a Plymouth Medical system, that is exactly what you should be expecting.
And we're talking a lot about the PRP. Let's just talk briefly about the other side.
Yeah, well, there's a couple of other sides. So the stem cells, and now we're careful when we call them stem cells because the FDA don't really appreciate that term. And I'm going to make this very, very simple from a patient perspective. If you are considering these types of treatments, you have to be very, very careful. Because again, you hear the word stem cell and a lot of people's guard drops and they think, oh, these are obviously the cells that we've been told about for years. They're going to fix me. No, they're not. Not necessarily. It needs to be done in the right way and the right cell needs to be used. Now, I will go on record and say the FDA are the people to look at for this. Stem cells are very highly regulated. We don't choose to use the term stem cell when we do a lot of our treatments. We call them stromal cells, and there's a lot of reasons for that. They are actually stem cells. The guy that identified them calls them stem cells. Arnie Kaplan, he's passed away a couple of years ago, but I don't know if you know him, he's an incredible dude. What is often being offered at clinics has nothing to do with stem cells. The only way you can get a treatment that is truly a stem cell is to have an autologous treatment. Autologous basically means the cells come from you, they are manipulated in a way that is acceptable per the FDA, and then they're delivered back to you. And the cells or the tissues that we use to get stem cells are either bone marrow or adipose. Anything else that is offered where the physician claims that it is a stem cell is not, because it would be considered an unapproved drug. Offshore, maybe in Cancun, places offering it, who knows what they're offering. They say they're stem cells. They might be, we don't know. But places that offer things like Wharton's jelly, which it's, obviously is in the pregnant woman that is full of stem cells. By the time it's processed, they extract and they remove all of the live cells from it. Anybody that offers amniotic tissue, also these products called exosomes. These are not FDA approved. They're experimental drugs and should be avoided like the plague. You cannot do that. If you want to do a stem cell treatment, if you choose to do one, it has to be autologous. So the cells have to come from you, they have to be processed and they go back to you. There are a lot of places that do it legitimately. Every single one of those people on that slide do it and they do it the right way. None of those people on that slide use exosomes, amnio, Wharton's jelly, or any of this kind of voodoo stuff.
And you mentioned there was a lot of sort of marketing also on using your fat to find cells, bone marrow also, and it's important where they take the bone marrow from. Not all your bones have the right bone marrow, so that's also an important key point. And placenta and amniotic fluid, things like that, also have come out there and utilized. And you see little studies and case studies about, oh, it works here or not work there, but you can get a negative effect from getting the wrong thing at the wrong place.
Yeah, one of the things you mentioned earlier, and I think it's really critical to point this out as well, is that we're talking about musculoskeletal stuff. You're an orthopedic surgeon. We're talking about soft tissue, so golfer's elbow, tennis elbow, plantar fascia, Achilles. We're talking about osteoarthritis, so the hips, the knees, the shoulders, the ankles potentially. One of the slides you mentioned earlier on had other things and neurological conditions, and this is where I take great exception to some of the stuff that has been offered over the past few years. Again, that underbelly, because these cells are fascinating, there are those that are trying to manipulate patients. For instance, there are centers that offer this as a treatment for autism. There's zero data to support using these stem cells will treat autism. Similarly for Parkinson's and for a whole host of other conditions. The autism gets me probably more than any because I'm the father of two incredible children. If one of my children had something wrong with them, I go to the ends of the earth to treat them. If a physician says, hey, thankfully my kids aren't autistic, but for those that are suffering, we have a potential treatment, I'd spend whatever it took.
Absolutely.
But the trouble is these treatments have no expectation of working. There is a really nefarious underbelly, and I really, that is disgusting. And I think some of those people deserve to be wearing orange jumpsuits. Strong opinion, but I think whenever you're conning somebody, I think that's not right.
It comes to marketing versus therapeutic treatment. And actually, in the last couple of minutes here, I do want to touch a little bit on coverage.
Yeah.
Insurance coverage. You wanted to bring that up, and I think it is important.
It is. It's frustrating. The insurance deem this as experimental in a lot of cases. And one of the things that works against this is The PRP that we've talked about here, the PRP that requires a lot of work, a lot of effort, and some frankly quite expensive equipment, is lumped in with the stuff that uses a test tube that costs 50 cents. They call it the same thing, so even just down to the definitions. And so whenever you give an insurance company the opportunity to say, well, hang on, they're not going to pay for something. The other side of it is they say, well, what is it you're delivering? So even if you are using a good system, your blood is going to be very different to my blood. And so the, sorry, this has just fallen off. One of the criteria that we're working with a lot of insurance carriers at the moment, and some of them are beginning to help us. So TRICARE and the VA healthcare system are covering PRP in the right cases. But again, they're not just covering any old PRP, they're doing it the right way, they're using the right equipment. In Connecticut VA, you can get access to my Plymouth Medical products if you need them. So yeah, it's confusing. We're hoping that the clinical data that we're working on, we're doing the studies that they're asking for, will propel them to at some point pay for it. But insurance, they're not out to treat them.
I understand.
We are going to be careful on that one.
We know.
They're
We know.
profit-making enterprises. These are expensive treatments. At some point, they'll have no choice. The data for good cellular therapies cannot be ignored. The trouble is we're diluted because there's data for bad cellular therapies as well. That gives them a chance to say no.
And then I want to thank you very much, Andy, for being on the show. If any more information, you can always look for Plymouth Medical as well. I'm Dr. Amit Lahav, and today we educated you on stem cells, platelet-rich plasma, and some regenerative medicine out there to make you smarter about the treatment you need to make you better. Thank you for watching our show. We'll see you next time.